So I will come back to introducing our speakers, Dr. Nancy Waltman and Ms. Laura Flores, but I want to introduce special guests in the audience who are part of this project, who helped this ensure its success. I saw Molly Lang, Kara Smith, and Mel Cole. So I don't know if you are willing to take your video off and wave to everybody. They were integral in having very important roles in this study. Molly is our laboratory technologist and director of the lab, and Kara and Mel both had study coordinator duties relative to this project. And with that, I'd like to introduce the speakers for today. My research partner and friend, oh, there's Kara, I see Kara, thank you. Dr. Nancy Waltman, who is a professor emeritus from the College of Nursing with a very long history of NIH-funded research relative to bone health in postmenopausal women. Healthy women as well as women who have had breast cancer. And she is, as I mentioned, a dear friend and a mentor and an excellent clinical researcher. And we're very lucky to have her here today. And then I also want to introduce Ms. Laura Flores. You may know her from seeing her in the halls of our building. She is an MD, PhD graduate student that works with me, but she's also fairly famous of late because she recently published a paper in JAMA. So she's been in UNMC Today, CNN, and many other places. So we're very, very proud to have her with us today. She has an interest in body composition and bone health and also health disparities. So with that, I'll let Laura begin our presentation for today.
Thank you. So I will be giving some background about the study, the Heartland Osteoporosis Prevention Study, also called HOPS, as well as some information about osteoporosis, which is the disease and disorder that we are investigating in our lab. So as was mentioned, our team today is Dr. Laura Bielik, Dr. Nancy Waltman, and myself, and we are multidisciplinary and passionate about bone health across the age spectrum and in at-risk populations. For this study in particular, we want to emphasize that osteoporosis and fractures are major problems in the postmenopausal women population. So this is a large 6-year R01 study funded by the NIH and NINR. And as Dr. Bielik mentioned, our success is attributed to all members, including our statistician, Kevin, Kara, Mel, and Molly, who are here today. For a little bit of background, 43 million women in the US have low bone mass, which is the disease immediately prior to osteoporosis. And compared to women with low bone mass, women with osteoporosis have a 2-fold higher risk of developing fractures. So experts agree that low bone mass in women requires treatment, but there's controversy about which treatment is best. I'll start with a little bit about how we build our bones throughout life. So bone health is multifactorial. That means many things go into our bone health. We have peak bone density, which is the highest amount of bone we build throughout our lifetimes. Diet can contribute to our bones. Smoking and alcohol can have negative effects on our bone health. Hormones are particularly important in women, and especially as we go through menopause. And for this study, we were interested in how exercise and medicine could contribute to our bone health. We did a little bit of work with body composition, which we will talk about as well. So again, bone health is crucial as we go through this menopause transition because it's a period of rapidly decreasing estrogen. And it's important to know that after a hip fracture, mortality is very high, and this can cause decreased quality of life and increased financial burden to women and to the healthcare system. So this study took place in Omaha and in Lincoln, and we worked alongside the Creighton Osteoporosis Research Center. To be included in this study, women had to have low bone mass. They had to be within 6 years of menopause and greater than 19 years of age. We also had a list of exclusion criteria. So women who were already osteoporotic or were taking medicines that might impact their bones, such as hormones or tamoxifen therapy or aromatase inhibitors, were excluded. Additionally, women had to have normal vitamin D levels, and they couldn't weigh over 300 pounds because of the parameters of our scanners for their bones. This study was a large randomized controlled trial, and it compared changes in bone structure, bone density, and bone biomarkers in 276 women. These women were randomized to one of three groups. The first group received calcium and vitamin D. This is our control group. Our second group received a bisphosphonate medication called risedronate. And our third group received an exercise intervention, which Laura Bielik will talk about briefly.
There is very strong evidence for both pre and postmenopausal women that an exercise intervention to improve bone health should include both resistance training and lower extremity impact exercise. These are some figures from our exercise training booklet for this study, and it shows Mel Cole demonstrating the exercises. We used resistance training with body weight and machines, and we had lower extremity impact exercise that involves a series of jogging exercises using a weighted vest, by which we progressively increase the amount of weight in the vest.
The data that we collected for this study included DEXA scans, which are a special type of scan that gives us information about bone mineral density, as well as body composition information, which is like lean mass and fat mass. We also received PQCT scans, which tells us more about bone structure, and Dr. Bielik will speak on that a little bit later. And we collected bone turnover markers. Our sample of 276 women was well split between the three groups. Everyone was around 54 years old with a BMI around 25. The racial and ethnic makeup of each group was similar and primarily Caucasian, and about half or over half of each group had a family history of osteoporosis. And with that, I will turn it over to Dr. Laura Bielik, who will discuss our bone structure findings.
A research question that we asked ourselves was, does physical activity and lean mass impact bone structure? Next slide. So what is bone structure, and how do we get data telling us about bone structure? This first slide just shows you the machine and the imaging technology that we use to assess bone structure. On the left-hand side is a scanner called a peripheral quantitative CT scanner. And this has an image of a woman with her lower limb slid through the opening in the scanner. And there's a technique to standardize the site at which you take the image, and you take a slice at pre-designated sites, and we'll talk about that in a moment. And you take a single image at those sites to get a three-dimensional image of the lower limb. This gives you volumetric information about the bone. The image in the middle shows a picture of your lower limb, the tibia, right above the ankle. You can see that orange bone is really kind of spongy or trabecular bone. And the image at the right shows your tibia or your shin bone about in the middle or slightly above the midpoint in your lower limb. Next slide. So what specific information can we get from this image? If you look at the left, you can see that the lines show where we take our pictures. The line at the bottom says the 4% site, and the line at the top says the 6% site. Those percentages say how far proximal from the distal end of the tibia the image is taken. So 4% proximal is the first image, and 66% proximal is the second image. At the 66% site, we get an image like the one on the screen. And it looks just like a hard bone that you might see if you have an arm roast, for example. It's just hard bone that's all cortical bone with an opening in the middle where you have bone marrow. And the main pieces of data that we would use from this is the cortical area. It tells us how much bone we have. So the bigger the bone, the more area, and the smaller the marrow area in the middle, the more bone you have. We also can get the cortical density from that image. And from the density in the area, we can calculate strength. The SSI strength measurement at this site tells us how strong the bone is from a 3-point bending test. It is a theoretical calculation using that data, but it is a torsional strength measure. So next slide, please. And at this site, again, at the very bottom, the 4% site, we get an image again, as is indicated on the screen. And here we have mostly spongy bone or trabecular bone with an outer cortical shell. That cortical bone on the outside of that spongy bone is very, very thin, and it's hard to differentiate between the two types of bone. So the measures that we can get here that we use in our calculations are total area for this bone and total volumetric bone mineral density. We call it volumetric because we calculate bone mineral density from a 3-dimensional image. We also have a strength measure that we get here, but this is more of this strength measure is indicative of resistance to compression. The bone has different needs at the 4% site, so we do a different calculation here. Next slide. Our study design, we use these outcomes from the PQCT, these bone structure measures, at the baseline visit for women who enrolled in the HOPS study. And our research question was, how are these bone structure measures impacted by the women's physical activity and lean mass status? The dependent variable, as I just mentioned, was the bone structure variables, and the independent variables were body composition measures and physical activity measures as determined by the Human Activity Profile Questionnaire. Next slide. Our first analysis was to do correlations between the different factors to determine initial relationships to inform our linear regression models. And here we don't have a regression table because tables can be overwhelming with numbers. So we tried to create an infographic to show you how these variables were related. And as you can see, height, body size, and lean mass, actually physical activity should have a smaller circle. But height, body size, and lean mass all had very robust relationships with the size and structure of the bone. Physical activity actually had a smaller relationship with the bone size. So to determine, to more accurately determine these relationships, we used linear regression. Next slide. And in this model, we looked at the outcome of each of the variables and what each individual factor contributed to that relationship. So if you look at the far left column, say cortical area, in the linear regression model, we wanted to look at how each individual factor might contribute. So for example, the AAS is the adjusted activity score, and that is the effect of activity on cortical area. If you look at the bottom, the alpha and the beta tell us whether the factors were significant. So if we look at AAS, we can see that activity, when we control for lean mass and height, Activity level had a significant effect on the area and strength of cortical bone at the 66% site or the mid tibia. If we look at lean mass had a positive effect on cortical area and strength at the mid shaft of the tibia. So I'm going to say that again. Activity and lean mass both had a positive effect on the cortical area and strength of bone in the mid shaft of the tibia. Now, what's interesting, if you look at cortical volumetric BMD, it's the second row underneath the 66% site. Go under lean mass, Laura, under there. If you see that's a negative number, this was surprising to us. And there are a couple of other studies that found the same result when controlling for height and activity. Lean mass had a negative relationship to bone mineral density when we controlled for activity and height. If we look at the effect of lean mass on the tibia at the 4% site or the very distal tibia, it had a positive effect on area density and strength. When we look at the effect of activity, it really didn't have an effect on the very distal aspect of the tibia. So let's go to the next slide. So in summary, what are our findings? Women with increased lean mass have better bone strength at the mid tibia and the ankle. Women with increased physical activity have better bone strength. And exercise and lean mass impact bone strength through improving structure rather than bone mineral density. And as I mentioned before, this was not our prediction. So this was a very interesting finding. And we're anxious to evaluate our 12-month data for this study to see what the intervention outcomes were. And with that, next slide. I hand off our presentation to Dr. Waltman to talk about the bone mineral density outcomes for the study.
Hi, I'm Nancy Waltman. Can everyone see me? No? Yes. Good.
You're good, Nancy.
Yes, Nancy, you look beautiful.
Well, thank you, thank you. Okay, next. This was a 12-month study, and we compared 3 groups randomly assigned, and one was a calcium vitamin D only, and the second one was risedronate plus calcium vitamin D, and the third one was a 3 times weekly bone loading exercise plus calcium and vitamin D. Next. And the aims of this presentation is to compare changes in bone mineral density at the total hip, femoral neck, and spine using a DEXA during the 12 months of the study. And based on assignment to one of the 3 groups, compare changes in bone resorption and bone formation over the 12 months based on assignment to group. And then I also want to describe some of the adverse effects of treatments, as well as the 12-month adherence to treatments. And remember what Laura said is that we are still we're still examining the data on bone structure for 12 months. So that will be an interesting finding too. Next. Our outcomes. First, the bone mineral density, and most of you are familiar with that. We used a hologic machine at Creighton, and bone mineral density is considered the preferred method of diagnosis of osteoporosis. It's the gold standard. We use the same hologic machine for all the patients throughout and certified technicians. Next. So we compared changes in bone mineral density, and we used intent to treat analysis or hierarchical linear modeling, which means that we had 276 subjects, And we used data for all these subjects, even though we had some subjects who withdrew before the 12-month analysis, before the 12-month testing. Results for our bone mineral density. For the hip and the femoral neck, there were no significant differences based on group assignment, no significant differences between risedronate exercise and control group. However, for changes in bone mineral density at the spine, there were significantly greater improvements in bone mineral density in the risedronate group compared to the other two groups. Next. And this is a percent change. By the way, the results are at the end of the PowerPoint. That's a PDF that we would be glad to send to all of you if you're interested in the actual data. But this just shows the increases in bone mineral density at 12 months per group. So for the risedronate group, for the spine, the increase was 1.9%, for the hip, 0.9%, and for the femoral neck, 0.09%. For the exercise group, increase was 0.9% at the spine, 0.5 at the hip, and it actually decreased 0.04 at the femoral neck. For the control group, it decreased both at the spine, 0.4, and at the femoral neck, 0.5. There was an increase 0.5 at the hip. So again, risedronate, improvements in bone mineral density at spine, hip, and femoral neck. Exercise, improvements at spine and hip, and then control group, only improvements at the hip. These numbers, these increases seem a little low compared to other studies. However, if you remember, we had early postmenopausal women, and generally these women lose bone. So just maintaining bone in these women is a positive outcome. Next. As far as serum biomarkers of bone resorption, which is the serum index, and bone formation, which was the ALK phase B, serum biomarkers measure rate of bone loss. So not the amount of bone mass, but are women fast losers of bone or slow losers of bone? And if women are fast losers of bone, and if they have low bone mineral density, they're very likely to fracture. So our goal is for serum index and ALK phase B to be reduced in all groups. And ideally, these bone turnover rates will be reduced to levels of a premenopausal woman. And in our study, the risedronate group had significant reductions in both serum index and ALK phase B compared to either exercise or control group. So that, next. I want to look at adverse effects. By the way, I just wanted to say that one thing about risedronate group looking so good with bone serum biomarker measures, such good reductions. The action of bisphosphonates is to inhibit osteoclasts. That's how they work, by reducing rate of bone resorption. That's how they improve bone mineral density. So you would really expect reductions in bone turnover with the risedronate group. Adverse effects, this is kind of interesting. Calcium supplements, it was constipation. And for most of these adverse effects, when they had the adverse effect, they did discontinue that treatment. For calcium supplements, what a lot of women did was they tried to improve their dietary intake of calcium then. Risedronate, the adverse effects were gastrointestinal, muscle or joint pain, and chest pain and dizziness. And muscle and joint pain, this was 10% of the women. So that would be a significant adverse effect. Vitamin D, 2 women stopped vitamin D because they said they didn't feel well, but we weren't certain what the adverse effect was. Exercises. Now, this is important too, because some of them did have minor soreness from the exercises. And so then Dr. Bielik and our Kate and Mel did adapt their exercises so that they could continue, but none of the women discontinued exercises because of adverse effects. 18 women did discontinue the exercising because they lacked the time, but this is not adverse effects. So the important thing is a lot of clinicians do not like to prescribe bone loading exercises for their women because they're afraid the women will injure themselves. They're afraid the women will fracture. And this was not true in our study. What clinicians need to know is if women are trained and monitored properly, they will not injure themselves with bone loading exercises. Next slide. Adherence. Exercise is the number of women who attended the fitness centers. And resedronate, calcium, and vitamin D, we measured them by pill counts. Next slide. So adherence rates to calcium and vitamin D were both high, over 90%. Adherence to resedronate, 74.9%, and exercise, 58.9%. Next. What was interesting is that as adherence to resedronate increased, the bone mineral density improved. And that's what you would expect to see, right? Increases in adherence, you'd expect improvements in bone mineral density. This wasn't true for exercise group. There was no relationship between adherence to exercises and changes in bone mineral density. And Laura and I were trying to think about that. And one explanation is that exercises improve cross-sectional area. In other words, they will increase the regional area in the outer bone, in the periosteum, as well as the inner bone that contains the bone mineral content. So bone mineral density, the ratio for measuring bone mineral density is bone mineral content divided by region area. So when we increase region area, we actually reduce the BMD measure. And this is kind of a, so it's almost inaccurate as a way of measuring impact of exercises. Next slide. So the conclusions of the study are, number one, all postmenopausal women with low bone mass should be encouraged to obtain adequate calcium and vitamin D and participate in bone loading exercises. And I need to say that calcium and vitamin D alone probably don't make that much of an impact on fracture risk, but they absolutely need to be, they're important, especially when you combine them with other treatments, such as exercise and resedronate. So yes, still encourage postmenopausal women to obtain adequate calcium and vitamin D. Participation in bone loading exercises, I will talk more about in the next slide. Why I would encourage all postmenopausal women to participate in bone loading exercises. For one thing, the benefits are tremendous, and really the adverse effects are pretty much rare or non-existent. The second conclusion is that yes, resedronate did increase bone mineral density, actually at the spine, hip, and femoral neck, but significantly at the spine. So therefore, yes, bisphosphonates such as resedronate do work, they are effective. They should be prescribed probably more than they are. And we talked about the fact that the serum biomarkers are significantly reduced in the risedronate group. However, exercise did still increase bone mineral density at the hip and the spine. And that was important. Next slide. So the discussion points. Number one, risedronate did increase bone mineral density and reduce rate of bone loss. Therefore, we found it to be effective, and women should be taking it. They should be adhering to risedronate, and clinicians should be prescribing bone loading exercises. Two, the other thing that's important to know is that bone mineral density is a strong predictor of fractures, but it's not the only predictor. As a matter of fact, only 1/3 of fragility fractures in women are due to low bone mineral density. I want to say that again. Only 1/3 of fragility fractures in women are due to low bone mineral density. There's other causes for fractures in women, and clinicians need to be aware of them. And other causes include poor bone structure, weak muscles, problems with balance and gait, and falls. And so what we're suggesting is that, for example, in the clinical area, that clinicians should assess all the risk factors in women and develop individual plans for women that may include bone loading medication, but also probably would include bone loading exercises, definitely includes calcium and vitamin D. For example, in older women, very, very old, 85 and older, generally these women, we don't even test them with bone mineral density because the reason they fracture is because of falls. And so we need to be aware of the many causes of fracture. And that concludes my part of the study, but I would like to turn it over to Laura Bielik.
Thank you, Nancy. And I want to continue Nancy's line of discussion about prevention of fractures and add that we recommend that for women at high risk of fragility fractures that individual programs be developed. And I know that my physical therapy colleagues are on, that we recommend that the women at high risk see physical therapists for individual programs. One, to look at fall risk, to have a fall risk prevention prescribed, and also to prescribe exercises that can help to maintain bone health, and also for safety of exercises to prevent fragility fractures such as vertebral compression fractures by exercising incorrectly. The next comment is when prescribing interventions for all patients, especially postmenopausal women that we're talking about, we want to make sure that we're including women in this conversation, because there are some women that are frightened of taking medication, but they're very happy to exercise, and vice versa. And so we increase our chances of success when we target our prescription to the lifestyle and desires of our patient. And this study shows that exercise as well as risedronate both had positive effects, although slightly different. A couple of last comments. We mentioned that we had partnered with Creighton and used their PQCT, but we should have our own PQCT on campus, hopefully soon. We're working on the details there. And a couple of takeaways from our presentation. Risedronate increased bone mineral density, but we believe exercise exerts its effects primarily on structure rather than BMD. And I think I beat myself to the last punchline there, which was women are more likely to be adherent if you engage them in the conversation about their treatment plan. So I think that's the end of our presentation, and we open up the floor to questions.
Laura, you know, I had a comment, and that was about the adherence to exercises, that it's not because of adverse effects, it's because of barriers such as lack of time. So next Tuesday, I'm presenting at, Laura and I and Mel Meisinger, our co-op, are presenting at Centric. We're doing a presentation on self-regulation to manage barriers such as lack of time.
Perfect reminder. Thank you, Nancy. And thank you all for coming. Does anyone have any questions?
I would remind them to let us know if they want the PowerPoint slides. And if there are any nursing faculty, please let me know and I'll send you the PowerPoint slides. You get the exact data.
Thank you, Nancy. And I see we have one question. What are the next steps in our research?
You're muted.
I think I muted myself. So did you hear me repeat the question?
Yes.
Okay. The interesting, what was interesting to me in our data analysis was the relationship of body composition to the outcome. And that is a finding that is newer in the literature, looking at the effect of lean mass on bones and also very much related to exercise. That is something that my colleague Laura Flores is interested in also. So we have 2 pilot studies that are related to this that are ongoing right now. Laura is the lead on a study looking at changes in bone and function after bariatric surgery. And she's conducting a randomized controlled trial to look at outcomes in patients who receive zoledronic acid, which is a bisphosphonate like risedronate, and patients who do not receive that medication. And the premise is that that medication not only preserves bone, but it may preserve lean mass. And so does it also affect the patient's functional outcomes after bariatric surgery? And we're also, again, doing a pilot study where we're looking at bone health in pediatric cancer survivors because they lose a lot of lean mass and have metabolic changes and also have many bone changes. And some kids have poor bone recovery. So we're looking at how their exercise habits and their lean mass recovery affects that. So we're taking the lessons learned in the postmenopausal women and applying them to those other populations.
You know, Laura, somebody asked about, did we look at whether falls were reduced in our study based on the bone loading exercises? And we measured falls, but we didn't we didn't do that. But that would be an excellent idea to examine whether incidence of falls was less based on in the women who exercised. We didn't do that, but it's a good idea.
And also the average age was 54. And so our population tended to be higher educated and healthier than probably the general population by self-selection for participation in clinical trials. So good questions. And we have some that are thanking us for our work in the presentation. Thank you for your kind comments. Any other questions? And if anyone, before everyone leaves, I want to mention that this is the first of a monthly seminar on that highlights the work of scholars in our college. And I forgot to double check, but I think Aman Ahmad is presenting next month. But we will definitely send the flyer out. And I want to thank all of you for coming. Nancy and I and Molly, Kara, Mel, we've all been working on this for years. And so it's been a pleasure to be able to share with you some of the results of our study.